of cancer and move on to biologic and targeted therapy. Biologic and targeted therapy is the fourth type of cancer treatment modality. Biologic agents may affect host tumor response in three ways. First, they have a direct anti-tumor effect. Second, they restore, augment, or modulate host immune system mechanisms. And third, they have other biologic effects such as interfering with the cancer cell's ability to metastasize or differentiate. Targeted therapies work at sites that are on the cell surface, at the intracellular level, or in the extracellular domain. Targeted therapy interferes with cancer growth by targeting specific cell receptors and pathways that are important to tumor growth. The targeted therapies are more selective for specific molecular targets than cytotoxic anti-cancer drugs. Thus, they're able to kill cancer cells with less damage to normal tissue compared to chemotherapy. Biologic testing can be used to identify whether specific targeted agents will be effective. The administration of one biologic agent usually induces the endogenous release of other biologic agents. The release and action of these biologic agents results in a systemic immune and inflammatory response. The toxicities and side effects of biologic agents are related to dose and schedule. Table 16.7 summarizes the potential side effects associated with specific biologics and targeted therapies. Acetaminophen and large amounts of fluid help decrease the severity of the flu-like syndrome. A wide range of neurologic deficits has been observed with interferon and interleukin-2 therapy. The nature and extent of these problems are not yet completely understood. However, these problems are understandably frightening to the patient and the family, who must be taught to observe for neurologic problems such as confusion, memory loss, difficulty making decisions, and insomnia, and report their occurrence and institute appropriate safety and support measures. Patients may experience infusion-related symptoms which can include fever, chills, urticaria, mucosal congestion, nausea, diarrhea, and myalgias. Bone marrow depression and fatigue are associated with biologic therapy. Capillary leak syndrome and pulmonary edema are usually acute or dose-limited and may require critical care nursing. There is also a risk, although rare, of anaphylaxis associated with the administration of MOABs. If this occurs, administration of the MOAB should be stopped immediately, emergency assistance obtained, and resuscitation measures implemented. Skin rashes are common in patients receiving EGFR inhibitors and manifest generally as erythema and acneiform-like rash that can cover up to 50% of the upper body. Proteasome inhibitors inhibit proteasome activity, which regulates cell growth. Side effects include bone marrow suppression, peripheral neuropathy, fatigue, diarrhea, nausea, and vomiting. Angiogenesis inhibitors bind vascular endothelial growth factor, and the side effects include hypertension, colon bleeding and perforation, impaired wound healing, thromboembolism, and hemorrhage. Many new targeted therapies are being developed and used more frequently. You need to become familiar with side effects associated with each agent. Hemopoietic growth factors are used to support cancer patients through the treatment of the disease. The name of the CSF, or colony-stimulating factors, is based on the specific cell line that it affects. See Table 1614. Erythropoiesis-stimulating agents, also called ESAs, should be used only when treating anemia specifically caused by chemotherapy using the most recent administration guidelines. ESA use is avoided in patients receiving chemotherapy with the intent to cure the disease. Use of these agents has raised safety concerns because they can cause thromboembolic events and increase the risk for death and for serious cardiovascular events when administered to a target hemoglobin of greater than 12. Therefore, the lowest dose should be used that will gradually increase hemoglobin to the lowest level sufficient to avoid the need for blood transfusion. The hemoglobin level should be monitored regularly. To prevent the debilitating cycle of fatigue that can occur in patients with cancer, an appropriate nursing intervention is what? To have the patient rest after any major energy expenditure, to encourage the patient to implement a daily walking program, to teach the patient to ignore the fatigue to maintain normal daily activities, or to prevent the development of depression by informing the patient to expect fatigue during cancer treatment. The correct answer would be B. Exercise and activity within tolerable limits are often helpful in managing fatigue. Walking programs are a way for patients to stay active without being overtaxed. Hemopoietic stem cell transplantation is an effective life-saving procedure for a number of malignant and non-malignant diseases. Bone marrow transplant or peripheral stem cell transplantation allow for the safe use of very high doses of chemotherapy agents and or radiation therapy in patients whose tumors have developed resistance or failed to respond to standard doses of chemo and radiation. Although these procedures are life-saving, patients may have long-term or delayed complications that can affect quality of life. See Table 1615 for more information. This therapeutic approach was typically referred to as bone marrow transplantation because the bone marrow was the original source of stem cells when the procedure was first developed. However, advances in harvesting and cryopreservation technologies have opened new pathways to the collection of stem cells from the peripheral blood. Consequently, the terminology has changed, and it is now referred to as hemopoietic stem cell transplantation, or HSCT. Even when cure is not achieved, transplantation can result in a period of remission. Because it is highly toxic therapy, the patient must weigh the significant risks of treatment-related death or treatment failure or relapse against the hope of cure. In allogeneic transplantation, stem cells are acquired from a donor who has been determined to be human leukocyte antigen or HLA matched to the recipient. Common indications for allogenic transplant are certain leukemias, multiple myeloma, and lymphoma. Syngeneic transplantation is a type of allogeneic transplant that involves obtaining stem cells from one identical twin and infusing them into another. In autologous transplantation, patients receive their own stem cells back following myeloablative or destroying bone marrow chemotherapy. Hemopoietic stem cells are harvested from a donor for allogeneic transplantation or from a recipient for autologous transplantation via two different methods. The process of harvesting was originally developed using bone marrow stem cells. The entire bone marrow harvest procedure takes about 1 to 2 hours, and the patient can be discharged after recovery. Post-harvest, the donor may experience pain at the collection sites, and that may last up to 7 days post-procedure and can be treated with mild analgesics. The donor's body will replenish the removed bone marrow in a few weeks. Because fewer stem cells are present in the blood than in the bone marrow, mobilization of stem cells from the bone marrow into the peripheral blood can be accomplished using chemotherapy and/or hemopoietic growth factors. Pyrexafor, brand name Mozabil, is a drug given subcutaneously that, when used in combination with G-CSF, boosts the number of stem cells released from the bone marrow into the bloodstream. Umbilical cord blood is rich in hemopoietic stem cells, and successful allogeneic transplants have been performed using this source. Cord blood can be HLA typed and cryopreserved. A disadvantage of cord blood is the possibility of insufficient numbers of stem cells to permit transplant to adults. Considerable research is currently ongoing to define the optimal application of this technology. Patients need to be prepared with a conditioning regimen before transplantation. During this period, when all bone marrow indices are low, it's critical for the patient to be protected from exposure to infectious agents and supported with electrolyte supplements, nutrition, and blood component transfusions. The occurrence and severity of post-transplant complications are also dependent on the drugs included in the patient's particular conditioning regimen. Some are more toxic than others, and the stem cell source. Because stem cells in peripheral blood are more mature than those harvested from the marrow, the hematologic recovery period in PSCT is shorter, and fewer, less severe complications are seen. Gene therapy is an investigational treatment that involves using genetic material to fight disease or replace missing genes to prevent the development of disease. In cancer care, some approaches assist the cell's ability to fight cancer. Others target cancer cells to destroy them or prevent their growth. At this time, the use of gene therapy is investigational. I've given you a website for additional information on this slide. Patients with cancer may develop complications from continual growth of the malignancy into normal tissue or side effects from the treatment. The patient with cancer may experience malnutrition, including protein and nutrient deficiencies, electrolyte depletion, dehydration, weight loss, and impaired wound healing. Soft, non-irritating, high-protein and high-calorie foods should be eaten throughout the day. Foods suggested for increasing the protein intake to facilitate repair and regeneration of cells are presented in Table 1616. High-calorie foods that provide energy and minimize weight loss are presented in Table 1617. Avoid extremes of temperature as well as tobacco, alcohol, spicy rough foods, and other irritants. Encourage nutritional supplements like NUR as an adjunct to meals and fluid intake. Weigh the patient at least twice each week to monitor for weight loss. Once a 10-pound weight loss occurs, it's difficult to maintain the nutritional status. Monitor albumin and prealbumin levels. Teach use of nutritional supplements, and enteral or parenteral nutrition may be required. Cancer cells may release substances that stimulate the bitter taste buds. The patient may also experience an alteration in the sweet taste sensation as well as the sour and salty taste sensations. Meat may taste bitter or bland. Frequently, the patient may feel compelled to eat certain foods because these foods are believed to be beneficial. Lemon juice, onion, mint, basil, and fruit juice marinades may improve the taste of certain meats and fish. Bacon bits, onions, pieces of ham may enhance the taste of vegetables. Infection is the primary cause of death in patients with cancer. The usual sites of infection include the lungs, GU tract, mouth or rectum, peritoneal cavity, or blood. Instruct patients with a risk for neutropenia to call their healthcare provider with a temperature of 100.5 Fahrenheit or greater. Assessment most often includes signs and symptoms of fever, determination of possible causes such as sinuses, mucous membranes, respiratory, GI, GU, and sites of any tubes or lines, and a CBC. The classic manifestations of infection are often subtle or absent in a patient with neutropenia and a depressed immune system. What are some of the teaching points that will help HJ while undergoing treatment? Some of the teaching points should include availability of resources, personal contacts, support groups, and literature, discussion of the treatment process and what to expect, and possible side effects of treatment. Oncologic emergencies are life-threatening and can result from the cancer or cancer treatment. They are classified as obstructive, metabolic, or infiltrative, and they commonly include superior vena cava syndrome, spinal cord compression, syndrome of inappropriate antidiuretic hormone secretion, hypercalcemia, tumor lysis syndrome, disseminated intravascular coagulation, and cardiac tamponade. Obstructive emergencies are primarily caused by tumor obstruction of an organ or blood vessel. Superior vena cava system is a good example. The signs include facial or periorbital edema, distension of the veins of the head, neck, and chest, seizures, and headache. A mediastinal mass is often visible on chest X-ray. The most common causes are lung cancer, non-Hodgkin's lymphoma, and metastatic breast cancer. The presence of a central venous catheter and previous radiation therapy to the mediastinum increases the risk for development of SVCS. SVCS is considered a serious medical problem. Management usually involves radiation therapy to a site of obstruction. However, chemotherapy may be administered for tumors more sensitive to this form of therapy. The next type of oncologic emergency that is obstructive in nature is spinal cord compression. The tumor is in the epidural space of the spinal cord, and signs include intense localized persistent back pain, motor weakness, sensory paresthesia and loss, and a change in bowel or bladder function. The most common cancers that cause this problem are breast, lung, prostate, GI, and renal tumors, and melanoma. Lymphomas may also pose a risk if diseased lymph tissue invades the epidural space. The use of radiation therapy in conjunction with corticosteroids is generally associated with some initial improvement. Surgical decompressive laminectomy is used for those with tumors that are not responsive to radiation or when the tumor is in a previously irradiated area. Activity limitations and pain management are important nursing interventions. Third space syndrome is another obstructive emergency. Third space syndrome involves a shifting of fluid from the vascular space to the interstitial space that generally occurs after extensive surgical procedures, biologic therapy, or septic shock. During recovery, hypervolemia can occur, resulting in hypertension, elevated central venous pressure, weight gain, and shortness of breath. Treatment generally involves reduction in fluid administration and fluid balance monitoring. Metabolic emergencies are caused by the production of ectopic hormones directly from the tumor or are secondary to metabolic alterations caused by the presence of the tumor or cancer treatment. Ectopic hormones arise from tissues that do not normally produce these hormones. Cancer cells return to a more embryonic form thus allowing the stored potential of the cells to become evident. Syndrome of inappropriate ADH involves abnormal or sustained production. Cancer cells are able to manufacture, store, and release ADH, and many chemotherapeutic agents stimulate their release. Syndrome of inappropriate antidiuretic hormone secretion is a syndrome resulting from abnormal or sustained production of the ADH by tumor cells with resultant water retention and hyponatremia, or hypotonic hyponatremia. SIADH occurs most frequently in carcinoma of the lung, especially small cell lung cancer, but can also occur in cancer of the pancreas, duodenum, brain, esophagus, colon, ovary, prostate, bronchus and nasopharynx, leukemia, and Hodgkin's lymphoma. Symptoms of SIADH include weight gain without edema, weakness, anorexia, nausea, vomiting, personality changes, seizures, oliguria, decreased in reflexes, and coma. Treatment of SIADH includes treating the underlying malignancy and measures to correct the sodium-water imbalance, including fluid restriction, oral salt tablets or isotonic or 0.9% saline administration, and in severe cases, IV administration of 3% sodium chloride solution. Furosemide or Lasix may also be a helpful treatment in the initial phases of SIADH. Dimethylcycline or declomycin may be needed on an ongoing basis for moderate SIADH. Monitor sodium level because correcting SIADH rapidly may result in seizures or death. Hypercalcemia is another oncologic emergency resulting from secretion of the parathyroid hormone-like substance, which occurs in approximately 10 to 20% of patients with advanced cancer and most frequently in squamous cell carcinoma of the lung, head and neck, cervical and esophageal cancer, lymphomas, and leukemia. Immobility and dehydration can contribute to or exacerbate hypercalcemia. Serum levels of calcium in excess of 12 milligrams per deciliter or 3 millimoles per liter will often produce symptoms, and significant calcium elevations can be life-threatening. Chronic hypercalcemia can result in nephrocalcinosis and irreversible renal failure. The long-term treatment of hypercalcemia is aimed at the primary disease. Acute hypercalcemia is treated by hydration, 3 liters a day, and biphosphonate therapy. Tumor lysis syndrome occurs less commonly with radiation therapy. TLS is often associated with tumors that have high growth rates and are sensitive to the effects of chemotherapy. The primary goal of TLS management is preventing renal failure and severe electrolyte imbalances. Tumor lysis syndrome has 4 hallmark signs: hyperuricemia, hyperphosphatemia, hypercalcemia, and hyperkalemia. This usually occurs within 24 to 48 hours after chemo and may persist for 5 to 7 days. Early symptoms include weakness, muscle cramps, diarrhea, nausea, and vomiting. Patients at risk for tumor lysis syndrome should be identified early and preventive measures implemented concurrently with chemotherapy. The primary treatment includes increasing urine production using hydration therapy and decreasing uric acid concentrations using allopurinol. Other oncologic emergencies include septic shock. Septic shock is discussed in Chapter 67, and disseminated intravascular coagulation is discussed in Chapter 31. Infiltrative emergencies occur when malignant tumors infiltrate major organs or secondary to cancer therapy. The most common infiltrative emergencies are cardiac tamponade and carotid arterial rupture. Cardiac tamponade is a fluid accumulation in the pericardial sac constricting of the pericardium by the tumor or pericarditis. Management is aimed at decreasing the fluid around the heart and includes surgical establishment of a pericardial window or an indwelling pericardial catheter. Manifestations include a heavy feeling over the chest, shortness of breath, tachycardia, cough, dysphagia, hiccups, hoarseness, nausea, vomiting, excessive perspiration, decreased level of consciousness, distant or muted heart sounds, and extreme anxiety. Supportive therapy includes administration of oxygen, IV hydration, and vasopressor therapy. Rupture of the carotid artery occurs most frequently in patients with cancer of the head and neck, secondary to invasion of the arterial wall by tumor or to erosion following surgery or radiation therapy. Additionally, bleeding can manifest as minor oozing, spurting of blood in cases of a blowout. In the case of a blowout, pressure should be applied. Surgical management involves ligation of the carotid artery above and below the rupture site and reduction of the local tumor. We'll move on now to cancer pain. A patient's report of pain should always be believed and accepted as the primary source for pain assessment data. Drug therapy should be used to control pain. Moderate to severe pain occurs in about 50% of patients who are receiving active treatment for their cancer and 80 to 90% with advanced cancer. These statistics have not changed in the past 30 years. The American Pain Society has released a clinical practice guideline that describes the management of cancer pain. You can find this at www.ampainsocc.org/pub/cancer.htm. Table 1619 presents assessment questions that may facilitate data collection. Undertreatment of pain is common and unnecessary. Data such as vital signs and patient behaviors are not reliable indicators of pain, especially long-standing chronic pain. It's important to distinguish between persistent and episodic, positional, or breakthrough pain. Therefore, it's essential that the comprehensive pain assessment include a detailed history to elicit the following characteristics of pain: quality, location, intensity, duration, and precipitating and alleviating factors. Differentiating between types of pain, such as visceral, bone, or neuropathic, is important in developing an effective pain management plan. Assess pain on an ongoing basis to determine the effectiveness of the treatment plan. Obtain data and document at regular intervals the location and intensity of the pain, what it feels like, and how it's relieved. Assess change in pain, that is, a significant change in intensity, character, or location, to determine the cause, such as might be the progression of the disease. Drug therapy, including nonsteroidal inflammatory drugs, opioids, and adjuvant pain medications, should be used. Teach patients how to keep a pain management diary. Other adjuvant therapies, such as antidepressants, anti-seizure drugs, may be beneficial in neuropathic pain, which is often resistant to opioids. Discuss the goals of analgesic therapy with patients, and especially for those requiring larger chronic doses of opioids. Treatment plans should be developed that balance analgesia and side effects in order to maintain optimal functional status. Patient teaching should clarify myths and misconceptions and reassure patients and family caregivers that cancer pain can be effectively relieved. Furthermore, addiction and tolerance are not problems associated with effective cancer pain management. As a nurse, you are likely in a key position to assess the patient's and family's responses and support positive coping strategies. Your nursing care can facilitate the development of a hopeful attitude about cancer and support the patient and the family during the various stages of the process of cancer. Common fears include disfigurement, emaciation, dependency, disruption of relationships, pain, financial depletion, abandonment, and death. HJ expresses one concern: pain. How should his pain be handled? While moderate to severe pain occurs in about 50% of patients who are receiving active treatment for their cancer and 80 to 90% of patients with advanced cancer, it's essential to perform a comprehensive pain assessment on an ongoing basis and to enact a pain management plan that addresses both components of pain if they are present. Assess the psychosocial concerns and emotional responses of patients and their families so you can connect patients with appropriate supportive care resources. To facilitate the development of effective coping and to support the patient and the family during the various stages of cancer, you should support the patient and family by being available, especially during difficult times, exhibiting a caring attitude, listening actively to fears and concerns, and helping to provide relief from distressing symptoms. Provide essential information regarding cancer and cancer care that is accurate and establishes realistic expectations about what the patient can expect to experience. Be open, honest, and caring in the approach. A squeeze of the hand or a hug at times may be more effective than words. Is a key to effective cancer care. Hope varies depending on the status of the patient. Hope that the symptoms are not serious, hope that the treatment is curative, hope for independence, hope for pain relief, hope for a longer life, hope for to achieve meaningful goals, or hope for a peaceful death. Hope provides control over what is occurring and is the basis of a positive attitude towards cancer and cancer care. Many patients with cancer benefit from a variety of psychosocial interventions such as supportive listening, stress management techniques, individual or group counseling, and cognitive behavioral therapy. Assess the psychosocial concerns and emotional responses of patients and their families so you can connect patients with appropriate supportive care resources. Cancer mortality is exceedingly high in older adults, with 70% of all deaths due to malignancy occurring in those older than 65 years. This is especially important because the normal lifespan is lengthening and the proportion of the population who are older than 65 is increasing. Age alone is not a good predictor of tolerance or response to treatment. Advancements in treatment of cancer are making cancer therapies beneficial to an increasing number of older adults, including patients with suboptimal health. Comprehensive geriatric assessment, or CGA, should be conducted at the time of diagnosis to identify important issues that might impact decisions about treatment options. These include projected life expectancy, estimates of morbidity from cancer, identification of comorbidities that could impact treatment, and assessment of patient decision-making capacity and wishes. The CGA includes assessment of functional status, socioeconomic issues, psychosocial distress, comorbidity assessment, cognitive function, nutritional assessment, and medication polypharmacy review. Some important questions to consider when an older person is diagnosed with cancer include the following. Will the treatment provide more benefits than harm? Will he or she be able to tolerate the treatment safely? Is there need to optimize other comorbidities or nutritional or functional status before starting treatment? And what are the patient's preferences and wishes? HJ is single with no children. He has no significant prior medical history and is taking no medications. What factors may influence his ability to cope? The ability to cope with stressful events in the past, availability of significant others, availability to express feelings and concerns, age at the time of diagnosis, extent of disease, disruption of body image, presence of symptoms, past experience with cancer, and attitude associated with cancer all affect coping. Survival rates have steadily increased over the past 30 years. The goal is to maintain an optimal quality of life. It's estimated that there are currently more than 12 million cancer survivors in the United States, with breast cancer patients making up the largest proportion of this group. Some of the individuals are cancer-free, while others still have evidence of cancer and may be undergoing treatment. Over the past 20 years, there's been a threefold increase in cancer survivors. With progressive advances in early detection and treatment, further increases in the number of cancer survivors are expected. The impact of a cancer diagnosis can affect many aspects of a patient's life. The cancer survivors commonly reporting financial, vocational, marital, and emotional concerns even long after treatment is over. The psychosocial effects experienced after cancer treatment can play a profound role in a patient's life after cancer, with issues related to living in uncertainty being frequently encountered. Cancer survivors experience a variety of long-term and late sequelae following treatment, including a greater risk of functional impairment, non-cancer-related death, and comorbidities including heart disease, diabetes, osteoporosis, and others. Provide all cancer patients with a treatment summary and care plan outlining treatment exposures, risk of late effects, preventive care recommendations, and a follow-up surveillance plan after completion of treatment. Care plans should clearly identify all members of the care team and their responsibilities for follow-up. Include referrals to appropriate supportive care and community resources that would benefit the patient in recovery or ongoing care. Coordinate care among the oncology team, primary care healthcare provider, and other specialists. Educate healthcare providers about the needs of cancer survivors, including long-term effects of cancer and cancer treatments. Teach cancer survivors to look for and report any ongoing symptoms resulting from treatment, including late effects of radiation therapy and chemotherapy. Promoting healthy behaviors includes prevention, which would be good nutrition, exercise, smoking avoidance, maintaining proper weight, cardiac risk reduction, and bone health, and early detection, which includes routine health screenings such as breast and colon screenings, cholesterol, diabetes, osteoporosis screening as recommended. Encourage cancer survivors to have regular follow-up examinations with an identified primary health care provider. Assess for psycho-emotional, financial, health insurance, or vocational problems related to cancer. Assist patients to get appropriate help if it's necessary. Both cancer incidence and death rates are disproportionately higher in African Americans than in whites and other minority groups. Differences in survival rate from cancer are attributed primarily to a combination of several factors, including poverty, difficult access to and poorer quality of health care, more comorbid conditions, and differences in tumor biology. Culturally competent care in oncology is needed to meet the needs of diverse groups. Culturally competent care involves awareness of personnel background, how culture impacts care delivery, and how to adapt to meet cultural needs. There is a need for nurses to actively seek to understand cultural differences to meet the individualized needs.